Hi, my name is Heather Bittner Fagan. I am a family physician and researcher at Christiana Care, and I'm going to talk to you today about lung cancer and lung cancer screening. Next slide. So this is publicly available data on the cancer death rates in the United States. I happen to choose the slide of cancer death rates among women, but I'll show you next that this looks very similar in men. And if you look at every color but red, you can see that the death rate for cancer is going down, in part due to better screening, better detection, and better treatment methods. However, if you look at the red line, lung and bronchus cancer is going in the opposite direction, and it is the leading cancer killer in the United States. Next slide. And this is just a similar diagram of cancer death rates in men to show you that I tell you the truth. It is also the leading cancer killer in men. Next slide, please. And one of the reasons that this is the leading cancer killer is that most lung cancers are detected secondary to some symptom, which means that we're picking them up at a later stage where they are less treatable. Next slide. But there's been great hope that all of that's going to change based on the National Lung Screening Trial. The USPSTF now recommends annual screening for lung cancer with low-dose commuted tomography in adults aged 55 to 80 who have a 30-pack year smoking history, currently smoke, or have quit within the past 15 years. And this recommendation was put out in 2013. Next slide, please. So that's really easy, right? We found we found what we need to do to make it all better. Not so. The lung cancer screening rate here in 2019 appears to be about 3, maybe 5% of the eligible population. So compare that with colorectal cancer at its lowest estimates is 63%, and mammogram also at its lowest estimates around 68%. So we're just not doing well at getting lung cancer screening implemented in the real world. Next slide, please. When lung cancer screening was recommended by the USPSTF, the next step in sort of making it a real world thing is for the Center for Medicare and Medicaid to say, yes, we will pay for that. In general, once CMS says that we're going to pay for something, the other insurances follow suit, and then that's sort of the first step to really implementing it in clinical practice. When CMS said that we would pay for this, they basically said for the first time of any kind of care giving, that shared decision making would be required, and they put out a pretty long document on what exactly should be, happening with this shared decision making. So what is shared decision making? Stated simply, it's a healthcare professional and a patient working together to make the best choice that fits for the patient. That choice being based both on the scientific evidence as well as the values and beliefs of that patient. Next slide. So why should we do shared decision making? It is a patient-centered outcome. It is considered to be a cost reduction strategy. There seems to be reduced litigation with it. CMS says we have to in order for patients to have this service covered. And one would argue that it's always the right thing to do when a patient is making a decision to make sure that that decision is something that they're very informed about and they're making one that fits. So those are some good reasons to do shared decision making. However, there's some question of how do we actually fit this into busy clinical practice, and who and how and when should shared decision making occur so that's both the highest quality for the patient without being invasive and burdensome and not really becoming a barrier to people getting their low-dose CT scan. Next slide. So I bring up this article because it was one of the early articles looking at how was shared decision making and lung cancer screening happening in real world clinical care. And they had a small qualitative sampling of pulmonologists and primary care physicians, and they followed them around. And basically, you know, the bottom line was physicians were spending less than a minute talking to patients about lung cancer screening. And, you know, it might be the best minute ever, but one would argue that this is not the ideal implementation of shared decision making. Next slide. So I believe that we can do better. And one of the first steps in doing better is getting out of the black box of that face-to-face visit with the physician. Some people are sometimes surprised to hear that, you know, most physician visits are only 20-minute visits. By the time you get the patient in the room and get some of the basic information, leaving time for charting, leaving time for, you know, what the patient was motivated to come in about, there's really not a ton of time to do these other things. So I am an advocate for leverage the physician recommendation, because patients really listen to their physician, but get out of that single moment. That shared decision making should be more than a single moment. There should be patient education that happens before the encounter, during the encounter, and after the encounter. And one of my favorite analogies is the way that shared decision making in the healthcare system works now is sort of like someone who wanders into a car dealership for a drink of water, and then these people are coming up to them trying to say, do you want to do this? Do you want to do that? When in fact, the way that we really make decisions, and important decisions, is we think about it, we learn about it, we talk to friends, maybe we go onto the internet. Then when we're ready, we talk to an expert, we get some more, you know, information and some more perspective, and then maybe, you know, we go out and we make the decision, and then we may need some help figuring out how to put it all into place. Next slide. So this is where my research comes in. I wanted to tell you about a study that I did prior to my current pilot. And what we did is we piloted an intervention of informed decision making to see how that did or didn't help lung cancer screening occur. We worked with one large family medicine practice that had 2 sites. We worked from the EMR data, identifying current and former smokers who were age eligible. We worked with the physicians to review their panels. We called patients, screened them for eligibility. We could do a whole 10-minute talk on how difficult it is to find out the pack years on patients. That data is not currently well captured in our EMR, or really from my discussions with any EMR. And then we scheduled them for a phone visit where they would do a decision counseling program. We mailed them materials in advance of that participation. Next slide, please. And this was the intervention. So over the phone, it is a non-persuasive intervention. So they've gotten sort of standard publicly available education. We ask them, you know, any questions about that. And then we talk to the patient about why they might want to screen and what things might make them not want to screen. The online tool prompts the patient to rate and compare these factors. And then it generates a decision score. And that score essentially classifies the patient into someone who wants to screen, someone who doesn't want to screen, or someone who is unsure. And it provides the key factors that matter in that patient's decision. And then we generate a 1-page summary, which is shared with both the patient and the physician. Next slide. And we were very excited to find out that the informed decision-making intervention actually predicted getting a low-dose CT scan. So this is good. We just wanted to do quality shared decision-making, and it actually showed, though, that it increased low-dose CT scan and increased lung cancer screening. With the caveat that these were pretty small numbers. We only had 28 people, and however, if you look at the crude numbers comparatively, the enhanced usual care, so the patients who we talked to that were like, yeah, you know, you're eligible, and they're like, no, we don't want to do your study, they screened at a rate of about 11%. The ideal patients, 45%, and patients who didn't participate in our study, none of them screened. So this is, you know, just feasibility study, no comparisons. We're not, you know, claiming that we've fixed the problem, but certainly promising enough that we said, hey, let's study this with a comparison group. Next slide. I know you're working on it, Erin.
Can you see it?
Yep. Okay. So some other data that we just sort of saw was that our current smokers were less likely to complete the decision counseling program. And there was a trend, again, small numbers, but it suggested that smokers and former smokers responded differently to this decision. And that former smokers, people who have, quit, basically came in a little bit more inclined to screen compared to smokers who were a little more reluctant. And we could talk about why smokers were reluctant if anyone's interested afterwards. Next slide. And this is just the typical consort diagram that you'll see in a lot of clinical studies. But for me as a researcher, this was like really the meat and potatoes. You'll notice that we had to start with almost 900 patients to get to R28. And, certainly that is a challenge in terms of, the feasibility of any study. So the first thing I want to point out is most of that dropout was really finding the eligible cases. Only about 18% were eligible. And you can look at all the reasons, there in detail, but basically it was about reaching the patients and about finding the patients that actually met those USPSTF criteria. Because again, we don't have pack years until we call them. And that, is something that eliminates a fair amount of people. 30 pack years is a lot of smoking. So our case finding rate is about 18%. Once we found the people who, were willing to participate, we had about a 52% recruitment rate. Again, small numbers, but so to me, what this says in path forward, if you're hiring staff or thinking about how to design this, it's not a recruitment problem. It's finding the cases. Next. And go ahead and bring up the arrows on this one. So in case you're thinking that it's really because, our team didn't do something right, or I'm not good at recruiting or finding patients, the VA consort, which, is a big consort of patients in the Veterans Administration, where they all have the same EMR. They do have an EMR that could collect pack years. They had very similar numbers. So basically, depending on how you cut it up here, they had about a 19% case finding rate, and then their screening rate once they, got people in the program was about 50%. So similar. Next slide. So, as I mentioned, we took lessons from the IDEAL study and said, what should we do next? Hence my current study called TIDIL, for testing informed decision-making in lung cancer screening. We are enhancing recruitment. We're doing that by, one, we are preferentially reaching out to patients who have an upcoming appointment. And this puts at the top of our list the patients who, have at least been, interacting with the system enough to schedule an appointment. So we have good phone numbers, and we're kind of gearing it up so that we could do our intervention right before they see their physician. We are working with current smokers. I didn't show you that data, but the current smokers, slightly more of them were eligible. We are adding a focus on smoking cessation because in order to really see the true benefit of lung cancer screening, we need to make the most of this teachable moment. We're adding a comparison group. We're going to do case-matched controls, and hopefully all of this will leave us with enough numbers to look at who's really being, pulled into the study and who's being left out. And by that, I mean looking at demographics to see, a little bit more about how do women versus men, white versus non-white, insured versus uninsured, or different types of insurance, how does that play out in terms of who's getting screened, who's willing to participate in the program, and who is not. And so we've, been lucky enough to work closely with our IRB to be allowed to look at some basic data in the patients who don't participate in the study. And we're really excited, and we hope that we can not only do good research and learn a lot that we can share regionally and nationally, but we're really hopeful that, we can move the needle on lung cancer screening and have a good effect on lung cancer mortality. And that, I believe, is my next slide. I think is the last slide. Oh, keep going. These are my acknowledgments. I won't read them to you. Keep going. Keep going. There's the references and some more. And I just want to say thank you very much. I'm happy to be here. And are there any questions?